Today we want to talk about approach to wheezes in children, specifically those who are between age of 1 to 5 years. We want to talk about what to do in history, differential diagnosis, examination, and management. In children who are younger than 12 months, the usual cause of wheezes are bronchiolitis. However, in children between 1 year to 5 years, this is actually quite common and many respond to short-acting beta agonists like salbutamol. It is divided into two groups, viral-induced wheezes and multiple trigger wheezes. Viral-induced is episodic wheeze that is only triggered by viruses, like any viral infection, and it will resolve during childhood, and it's not related to atopy. However, in multiple trigger wheezes, child wheeze is intermittent at time even when there is no viral triggers. So triggers can include crying, playing, or even laughing. In history taking, we want to ask about previous episode. Is it the first time that child is experiencing any wheezes, or is it recurrent? Is there any known triggers to their wheezes? If there are previous episodes, how frequent are they? And how severe are they? Has the child needed any hospitalization or corticosteroid treatment? Has the child experienced any upper respiratory tract symptoms before the wheeze, such as fever, cough, and rhinorrhea? We can ask about the well baby questions. Is the child sleeping well? How is the feeding? And how's the activity and fluid intake? In past medical history, we ask about any history of eczema, cardiac and respiratory problem that can affect the treatment. We ask about family history of asthma or any atopy. We ask about if there's any pet at home or is the child exposed to secondhand smoking. So, differential diagnosis of a child presenting with wheeze can be pneumonia. Children who are presenting with pneumonia are usually unwell, toxic, with focal chest finding, grunting respiration, or fever. It could be aspiration. Aspiration is considered when a child has a neurodevelopmental disorder or feeding disorder. Congenital structural anomaly is another differential diagnosis. It is considered in cases such as laryngeal web, bronchomalacia, tracheomalacia, bronchogenic cyst, congenital cardiac disorders. Another diagnosis could be chronic bacterial infection. We consider chronic lung disease such as cystic fibrosis or primary ciliary dyskinesia that can cause persistent bacterial bronchitis. Another diagnosis could be immunological disorder. So in these cases, we expect to see failure to thrive or a history of recurrent infection. And the last differential diagnosis is foreign body. It is considered if there is localized wheeze and history is positive for possible choking. In physical examination, the most important thing to do is to assess the severity of wheeze. So if the wheeze is mild, the only positive finding in examination is slight increase in respiratory rate and slight increase in heart rate. For example, in a child who is between 1 and 5 years, the tachycardia would be expected to between 140 and 150. However, if the wheeze is moderate, we expect to have some positive finding. For example, in the appearance, the child is breathless and can complete short sentences. Respiratory rate is increased and is between 50 to 60. Tachycardia is present and it's between more than 150 to 170. And there's moderate chest wall retraction. If it is severe, the child appears to be breathless and has a feeding problem, is agitated and distressed. There's marked increase in breathing more than 60, marked increase in heart rate more than 170, and marked chest wall retraction. If the child's situation is critical, usually the child is confused and drowsy and unable to talk, or even we can have a silent chest. There is maximal work of breathing and the marked tachycardia more than 170, or even we can have bradycardia. There's also marked accessory muscle use or recession. Apart from general appearance, a vital sign is important for us. Height and weight and plotting them against the growth chart. Examination for cardiac examination, respiratory examination, and also ENT examination to check for any upper respiratory tract infection. Management in acute setting. If there is critical or severe respiratory distress, we call 000 for urgent transfer to ER. We start oxygen. We start giving salbutamol every 5 to 10 minutes while we're waiting for the ambulance. If we have nebulizer, we can give 2.5 milligram with nebulizer with oxygen. If we don't have nebulizer, we can give salbutamol 6 puff with a mask and spacer. And between doses, we can give oxygen with a mask. However, if the mask is causing distress to the toddler, we can hold it close to the nose and mouth. If there is any deterioration, we can consider continuous salbutamol or anaphylaxis as a possible diagnosis. So we can give intramuscular adrenaline 0.01 milligram per kg body weight to a maximum dose of 0.5 milligram IM, which is equal to 0.5 milliliter of 1 in 1000. If needed, we can repeat it 5 to 10 minutes. If the distress is moderate, we start salbutamol with spacer and mask, 6 puff every 20 minutes for an hour. Then we assess regularly. If dramatic improvement, no ongoing salbutamol is required, and no return of respiratory distress after period of observation, we can consider home management with reviews. If there's ongoing symptom, again we call 000 for ambulance transfer to the ER. If symptom is mild, we demonstrate technique by giving 4 puff of salbutamol with spacer and mask and assess effectiveness by re-examination. So in the picture, you can see what is the best way to give salbutamol to the toddler. Legs are held between parent's leg. Arms are restrained with one hand, and with the other hand, chin is in cusps of the hand with a spacer. For general management, if the child has a multi-trigger wheeze or a history of atopy, we manage it as for asthma. So we can prescribe salbutamol only if there's a response to it, and we do not prescribe steroid for children who have only episodic viral-induced wheezes because it provides no benefit. We should not also prescribe antibiotic for viral-induced wheeze. If associated sign and symptom are present suggesting a differential diagnosis such as failure to thrive, we should consider non-urgent pediatric assessment. Inform parents that management is similar to asthma and provide children with asthma management plan. Most children will grow out of this by middle childhood. A review is needed to assess diagnosis of asthma at age of 5 years. Recurrent episodes are common and parents are to initiate salbutamol with a spacer and mask if this occurs. Most children with occasional viral-induced wheeze do not need preventive treatment. Preventive treatment is needed if there is recurrent episodes, like every 4 to 6 weeks or sooner, or the severity of flare-up are moderate to severe or even life-threatening. Options include low-dose inhaled corticosteroid, and if appropriate, we can think of montelukast as well. Advice for influenza vaccination is also important. If trial of preventive therapy failed, we should consider non-urgent pediatric assessment.